Hi to everyone. I'm happy to be here with you tonight. Among the last speakers. Okay, so let me see how it works. Like this. Okay, so I'm going briefly to talk about the work we have done with the Migrant Health Working Group of the International Foundation for Dermatology, ILDS. This is a figure of the refugee crisis around the world. You know that the number of refugees worldwide and forcibly displaced people is on the rise. I don't need to mention the humanitarian crisis around the world. We reach 123.2 million of people displaced worldwide. And you know that these people face complex vulnerability related both to this discontinuation of care and special medical needs, sexual reproductive health, non-communicable disease, sexual violence, and mental health, among others. And that this situation plus the living condition increase the risk of skin diseases due to displacement and lack of trained healthcare workers and also limited access to medication. This is a photo from Lesbos refugee camp from Doctors Apostolos of Intersos. And look, these are refugee camps in Europe, not in Africa, nor in low and middle income countries. And you can easily understand how the living condition of these people impact their skin health. So the Migrant Health Working Group is an amazing initiative, in my opinion, that brings together global specialists to discuss and address skin and sexual health issues facing migrants and refugees. And this is a photo from Lebanon, in the Bekaa Valley, where we are working with Claire and with a group of other colleagues from Lebanon and internationally. We basically develop a technology integrated healthcare model to improve the skin care in a displaced population setting. What is this model? It's based on 4 main pillars. So a need assessment, this is what we were doing in the previous photo. So we were checking migrants, refugees in the country and the local, and offering dermatological consultation to the local population to assess the prevalence of skin condition. And we were listing the most common, let's say the top 5 that were causing the 80% of the skin problem locally with the local epidemiologic. We develop a capacity building training model based on some module targeting the skin condition. We then adapt this model to the local needs and to the local epidemiology of skin conditions. And we support healthcare provider after training with teledermatology, thanks to a collaboration with a teledermatology provider. In this moment, we are working with Consultant Connect, which is the UK telemedicine provider. And we try always to integrate our intervention with the local care system, collaborating with the local dermatological society, and using also the local medication. So trying to obviously fuel the local market and try to use the medication available locally. So this program was implemented, as you can see, in 3 different settings, in Cox's Bazar, Bangladesh, in the Bekaa Valley, and the Kigoma region in Tanzania. We choose this area because there are areas of crisis, humanitarian crisis, where, you know, Kigoma region, we were in Kigoma in Tanzania in January 25, and also because of the particular relationship we have with the local dermatological society, or in this case with MOSHI, the Regional Dermatology Training Center. Kutubaloon camp in Cox's Bazar was chosen because it has the highest prevalence of refugees in the world. So there is a huge camp, and the needs in terms of skin diseases, especially infectious disease, are really huge. And the Bekaa Valley, because of the displacement from the beginning of the Syrian war, it was over 11 years of 1.5 million Syrian refugees, 1 in 5 compared to the local population. These are photos from Cox's Bazar. Our mission, I go quickly on this because for sake of time. So we ran this, we were together with Prof. Griffiths and with Toby Maurer and Sidra Khan. We ran, and together with the doctor, the dermatologist of the Chittagong University, we ran some clinics in the camps, dedicated skin clinic, in collaboration with NGO and also with local healthcare provider. We assessed the infrastructure, so the needs in terms also of medication, and we met with local stakeholders to discuss their dermatological needs. We did an assessment. We were a team of 7 dermatologists. We ran 3 days clinic, so we don't stay there for a long time. Also, travel takes long because usually the refugee camps are located at the border with other countries. Also, reaching these areas is particularly challenging. And we collaborate with local organizations. As you can see, the top 3 categories of diagnosis represent the 78% of all the skin diagnosis. So fungal skin infection, dermatitis, and bacterial skin infection. Once you teach to the local healthcare providers, I mean to non-dermatologists, how to recognize this skin condition, you already address, and how to treat them, you already address the 80% of the skin condition in the area. So you can then support for the remaining 20% with teledermatology. So it's a very easy, straightforward model. And why skin? Because as you can see, the prevalence, according to the local data, the prevalence of skin condition is very high, among the top 5 reported in the primary healthcare centers. I don't go on the logical framework here, but obviously then we set up a project and we try to raise a fund for this project to continue the project locally. We usually identify a local champion, or we work with the UNHCR and with a doctor who provides service in the camp to run the teledermatology, and we support them with monitoring and evaluation mission. This is a photo of the skin condition we saw during this mission. You can see these are fungal infections. We have an issue related to dermatophytosis, especially coming from the Southeast Asian continent and Bangladesh in particular, because they're resistant to all the antifungal treatment available. And this issue, I mean, is not only there. We are seeing it here in Europe. We have a project funded by EADV. I'm also partner of this project. And it's very challenging to treat patients coming from that area of the world because they keep on relapsing and they don't respond to their terbinafine anymore. So easy to set up, easy to say, but not to do really. Sometimes it's very challenging, but high burden of skin disease, geographic location with limited access to healthcare providers, also related to the monsoon season. Everyone has a smartphone and there are no local dermatologists, so teledermatology can be the solution. And this is a photo from the group in Lebanon, so jumping from Cox's Bazar to Lebanon, where we were in 2023 for in presence field assessment in collaboration, I mean, a mission funded by ILDS, AFD, but in collaboration also with the local NGOs and with international NGOs like MedGlobal. While Lebanon, I mentioned before, 1.5 million Syrian refugees, 90% live in extreme poverty, but also a lot of local Lebanese people living under the poverty line due to the severe socioeconomic crisis, and dearth of medical staff. So a lot of doctors, also a lot of dermatologists have left the country because of the economic crisis. So the same modality, we ran a mission in Lebanon in May 23. We were 10 dermatologists from different countries, a lot of Lebanese colleagues, thanks to the collaboration with the American University of Beirut and Prof. Kibi that support our work there. We ran a 7-day field mission in the Bekaa. We visit around 500 patients, and also here we identified the top, the big 5, let's say, usually, dermatitis, skin infection, and infestation, as you can see from this graphic. Capacity building, we train 150 dermatologists because we give some lecture during the Lebanese Dermatology Society meeting 12 local, then we focus our training also to local staff of NGOs in the Bekaa Valley, because we travel from Beirut to the Bekaa, and we identify local champions that kept on working, carrying on some work and pilot our project, and did some teleconsultation with my support, and then we extended the project in a phase 2 due to the crisis and the bombing of the south of Lebanon. Many people from Lebanon were displaced to the capital city and the north of Lebanon, the Akkar region, and so we start also working there with the same modality, but this time we were not able to train the people in presence, so we deliver, thanks to my colleagues, we deliver online sessions, teledermatology, online training, and we support them with teledermatology, and this project, the second phase of SCAP, is still ongoing in the northern area of Akkar. We are planning to go there soon, hopefully at the beginning of next year. And we are trying to work with the WHO, with Dr. Postigo, who is here with us today on the Skin NTD and Common Skin Condition Hub. The WHO Hub is a useful tool to help and to support the clinical skills of non-dermatologists in the field, so mainly in healthcare providers working in the refugee camps. And we try to also validate this app. I hope we can manage also for Lebanon. These are photos of common skin infection, as I showed you before. So the doctor who is not able, after the training, is able to identify the common skin condition, but those that is not able to identify, he just take a photo. We send the picture through Consultant Connect, not only the photo, but also a description of the case. And we are dermatologists, 3 or 4 dermatologists from Europe and 1 in Lebanon, that develop a synchronous teleconsultation, but we are very fast. On average, we answer in few minutes. Tanzania is last mission. I go fast. These are the 2 camps where we work. It was an amazing experience together with a colleague of the Moshi Regional Dermatology Training Center and in collaboration with the UNHCR. We saw a huge number of patients, over 1,000 patients in few days, and 48% were under the age of 18, 70% were suffering of skin condition for over 6 months, so chronic condition because of the delay access to skin care, and 22% of the patient more than one two skin diagnosis. The most common were fungal infection, but also scabies was identified, and we move from a camp to another. Also in that case, it was quite challenging to reach the camps. These are common conditions, tinea capitis. All of you is an expert, I think, on this. This is a list of medication that we bought locally, and we use almost everything, basically. So we had a list of essential medicine that we purchase and we distribute. The remaining was left to the camps. These are our follow-up recommendations. So many patients to be followed up in the camps by the healthcare provider that we train on the job. We didn't have time to train online on a theoretical training, but only on the job. Other to be referred because they were extremely severe cases, and other were referred to a follow-up via teledermatology. In conclusion, basically this is our model. I describe it. It helps to improve access to dermatological care for refugees and local population, improve clinical skill of local care providers, reduce unnecessary referral, and enhance community-based management of skin condition. It facilitates also timely consultation and continuing medical education in resource-limited setting where there are no dermatologists, and also potentially strengthen the partnership with local dermatologists that we hope will take care also of this population in the future. And is essential, obviously, monitoring and evaluation of your project when you set up this kind of activity or pilot project. And with this, I conclude the takeaway message. This initiative highlights a scalable and suitable model for improving scale health among displaced population by using teledermatology training and the local partnership, but future efforts should focus on policy integration, sustainable financing, and expanding teledermatology to enhance access to dermatological care in humanitarian setting. That's why we are here, and we are also collaborating in partnership with the WHO. And I really thank all the members member of the Migrant Health Working Group that support me. I thank Claire Fuller, who is here, that she is a good champion, and we all advocate for better healthcare for refugees and displaced people worldwide. Thank you.